Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we kindly ask you to hold your question and comments till the end, at which time you may mute yourself or put your comments in the chat box. Lastly, the CME credit on the screen will be displayed at the beginning and at the end of the presentation. Today's speaker is Dr. Marco Sarvin. Dr. Sarvin is a renowned professor of ophthalmology and neuroscience and current chair of the Institute of Ophthalmology and Visual Sciences at Rutgers, New Jersey Medical School. Dr. Sarvin completed his MD PhD at the Johns Hopkins Medical School as part of the Medical Scientist Training Program. This was followed by a medicine internship at the Dartmouth Hitchcock Medical Center, followed by his ophthalmology residency and fellowship at the Wolmer Ophthalmological Institute of the Johns Hopkins Hospital. Throughout his academic career, he has been awarded multiple grants from institutions such as the National Eye Institute, the Department of Veteran Affairs, and many others. Dr. Sarvin's research is focused on the development of treatments for age-related macular degeneration. He has co-authored more than 240 peer-reviewed publications and more than 120 book chapters, while also serving as editor for two leading journals of ophthalmology and ophthalmology retina. Please join us in welcoming Dr. Sarvin and his presentation on age-related macular degeneration, pathogenesis, and therapy.
Thanks very much for that generous introduction. Please, everybody, there's the number to text and the code. I'll show that at the end. Yes, I'm going to speak about AMD, age-related macular degeneration, pathogenesis, and therapy. These are my disclosures. I'm a consultant for a number of companies that make relevant products. The outline of this is first I'm going to review some aspects of ocular anatomy for those of you who may not remember it, and I'm doing it just because I think it'll facilitate an understanding of the definition, the clinical manifestations, the histopathology of the disease, which I think lends itself in turn to a deeper understanding of the pathophysiology and the rationale underlying established therapy. And then at the very end, I'll mention some therapies that are in development, some of which I think will come online soon. So regarding the anatomy, I'm sure you all know that the cornea is responsible for 2/3 of the refracting power of the eye, the lens for 1/3. The vitreous gel is a non-Newtonian viscous fluid. The retina is just an extension of the central nervous system. The choroid is a vascular layer supplying blood flow to the outer 1/3 of the retina. And the sclera is a fibrous tunic that protects the neural tissue. The optic nerve really sends a binary output to the rest of the brain. The visual signals are actually disaggregated in the retina. This disaggregated information is sent to the lateral geniculate, the striate cortex, and then it's reaggregated in the parietal association cortex, and that's actually where visual percepts occur. This is a human postmortem collage showing the lens, the retina, pars plana, the pars corona, the ciliary processes, and the ora serrata. Now, the retina lines the inner, say, 4/5 of the eye, but in fact, only a small part, the macula, subserves high acuity vision. It occupies about 4% of the total retinal surface area. And, you know, when you look with a direct ophthalmoscope, what you're seeing is a very small fraction of the retina. So you see the artery, the vein, the nerve, the macula, which actually is a clinical term. It doesn't really have a precise histological correlate, and then the fovea. And then if we look histologically, of course, there's the retina, the vascular cord, and the sclera. And the macula, we could say, is an area of the retina that has a ganglion cell layer that's about 2 cells thick or more. So remember, here's the ganglion cell, the internuclear layer with the bipolar cells, and the photoreceptor layer. And then in the fovea, we have just cones. They're specialized cones that are rather slender. And Mueller cells. And you'll just take a moment to notice that the outer segments of the photoreceptors are very highly oriented, like the teeth of a comb. Now, if we think about the visual acuity and how it's distributed across the retina, on the graph on the left, I'm plotting visual acuity on the y-axis as a function of distance on the x-axis, with the 0 point assigned to the foveal center. And as you move away, so at the foveal center, you have, say, 2010 or 2015 vision. And as you move away from the foveal center, there's an exponential decline in the visual acuity, so that by the time you're about 500 microns away, your visual acuity has dropped to 20/60. And the point I want to make is that if you have a disease process that proceeds in a linear manner, you will see that it's correlated with an exponential, that is to say, an accelerating rate of visual loss. Underneath the retinal pigment epithelium is a pigmented cuboidal layer of tissue. The RPE nourishes the photoreceptors. As you probably remember, provides 11-cis retinal to the photoreceptors, which is the visual pigment. And it phagocytizes the oxidatively damaged outer segments of the photoreceptors, which are shed on a daily basis. The RP sits on a fibrous membrane called the Bruch membrane, which is generally described as comprising 5 layers: the RP basement membrane, an inner and outer collagenous layer separated by a discontinuous lamina elastica, and then the basement membrane of the choriocapillaries. And then, of course, the cord supplying blood flow to the retina and specifically to the photoreceptors in the RPE. Now, I'm sure you all remember that the retina has a dual blood supply. The inner 2/3 of the retina, so that's the ganglion cells and the bipolar cells, are supplied by the central retinal artery and its branches. But the outer 1/3, which would be the photoreceptors and the RPE, are supported by the choroidal vessels. And the photoreceptors have an extraordinarily high oxygen consumption. They actually operate under conditions of aerobic glycolysis. So any interruption of choroidal blood flow can very quickly lead to dysfunction and death of the photoreceptors. And that's going to be very important in thinking about AMD pathogenesis. In fact, if you plot on the y-axis the oxygen tension as a function of depth into the photoreceptors on the x-axis, if you start at the choriocapillaris, the oxygen tension is about 70 torr. By the time you get to the internuclear layer under conditions of light, where the retina is chronically hyperpolarized, you're down to 10 torr. Under the dark, where it's chronically depolarized, you're down to 0 torr. So very little flexibility built into this system. One of the remarkable things is in ophthalmology is the ability to image the retina in a living patient. So on the top is obviously histology of the retina, and on the bottom is an image called optical coherence tomography. And the way this is constructed is that you shine in a laser beam, typically 850, anywhere between 850 and 1050 nanometers. And that light interacts with the tissue, and so the reflected light is out of phase with the incident light. And the degree to which it's out of phase is, of course, influenced by the degree to which it's interacted with the tissue, so a measure of the tissue's optical density. So with that said, you can create an image of the retina that's about 2 to 3 microns in resolution. So for example, there's the outer nuclear layer histologically. There it is on the OCT. Here is what's called the ellipsoid histologically. The ellipsoid is an aggregation of mitochondria in the inner segment of the photoreceptors, and that creates a highly reflective band on the OCT. Then we have the retinal pigment epithelium, which contains pigment that basically reflects light, and so it creates a highly reflective band on the OCT. And then finally, we have the outer limiting membrane, which is just a heterotypical junctional complex between the Mueller cells and the inner segments of the photoreceptors, and that creates a reflective band. And in fact, the outer limiting membrane is only about 2 microns thick, so that gives you a sense of just how high the resolution of this system is. Okay, so now with that said, we can talk about macular degeneration. So what is it? It's a condition characterized by the extracellular accumulation of abnormal membranous debris under the retinal pigment epithelium and between the RPE and the photoreceptors. And it's the leading cause of blindness in the United States, with a prevalence of about 18% among persons between the ages of 45 and 85. The manifestations of it, the hallmark is something called drusen and subretinal drusenoid deposits. So this picture, the black arrow, is pointing to something that we call large soft drusen, those yellow spots. We also have detachment of the retinal pigment epithelium from Bruch's membrane, and we have eventually atrophy, degeneration of the photoreceptors, the RPE, and the choriocapillaris. And that's illustrated in this picture. The black arrow is pointing to a depigmented area, which actually is an area of atrophy. And then probably, as you'll see, in a reaction to this impaired blood flow, we have choroidal new vessel formation, which arises from the choriocapillaris. And those vessels are abnormal. They leak fluid and blood and cause scarring. And here, the choroidal new vessel is manifested by the presence of subretinal hemorrhage due to the leakiness of the abnormal blood vessel. Okay, The presence of atrophy or choroidal new vessels are both comprise something called late AMD. And late AMD globally by 2040 is going to affect more than 18 million people. And its prevalence quadruples with every 10 years of age over the age of 50. So a very important public health problem, because once you lose your central vision, you can't read, you can't drive, you can't recognize faces, you can't thread a needle, you can't do neurosurgery. This is a schematic illustrating the anatomy of soft drusen, and you can see that their RPE is detached from Bruch's membrane, and it's detached by this abnormal extracellular material, which is membranous, and the membranes comprise esterified and unesterified cholesterol. Now, in contrast, something called subretinal drusenoid deposits involves the deposition of abnormal extracellular membranous material between the photoreceptors and the RPE. It's less distinct clinically, as I'll illustrate in a minute. And it has a different biochemical composition. It does not have esterified cholesterol, just unesterified cholesterol. So here's a clinical photograph of soft drusen. And here's what soft drusen look like on the OCT image. I'm going to compare the histology and the OCT image just for clarity's sake. So on the right, you can see the photoreceptors, and the photoreceptors are evident in the OCT where that red arrow is pointing. The RPE, which is that highly reflective band, is also evident on the OCT. And the drusen material is apparent on the OCT as this material that's detaching the RPE from the underlying Bruch's membrane. Now, the subretinal drusenoid deposits clinically are much less apparent generally, and I've chosen a photograph in which they're particularly apparent. But you can see even here that they have a less well-defined border. They're sort of flatter in their appearance. And if we look at them on the OCT, they appear as these areas of highly reflective material interposed between the retinal pigment epithelium and the outer nuclear layer. And those magenta arrows are pointing out specific accumulations of subretinal drusenoid deposits. Histologically, what they look like are shown by those red arrows. You can see it's sort of vesicular material. For those of you who are familiar with retinal anatomy, what you'll also notice is that the normal, very strict orientation of the outer segments is disrupted here with a kind of random orientation, and the outer segments are shorter than normal. And in fact, if we were to measure photosensitivity over this area, what we'd find is that it is abnormally reduced. So choroidal neovascularization, shown on the left, is associated with bleeding and visual loss. And atrophy, shown on the right, is also associated with visual loss. But when you look at this picture of atrophy, you see these large, deeper vessels. The reason you can see those deeper choroidal vessels is because the RPE in that area are missing. And the melanin is what creates this orange glow that you normally recognize as the background of the fundus. So when you have choroidal neovascularization, you have abnormal tissue present. And when you have geographic atrophy, you have an absence of normal tissue. Well, it turns out that you can be remarkably accurate in offering a prognosis to patients based just on their clinical exam. And the risk factors are listed in this table on the left. So what are they? If you have a bilateral intermediate drusen, so this would be drusen about 60 microns in diameter, which is about half the width of a vein at the optic nerve, that's a risk factor. If you have a large soft druse, just one, that's a risk factor. Or macular pigmentary change, which appears like these little black areas in the retina. That's a risk factor. And then as you add the risk factors, your risk score increases. And as your risk score increases, the probability of developing late AMD in at least one eye over 5 years increases correspondingly, as you can see on the far right. And then it turns out that if you also happen to have subretinal drusenoid deposits, your risk is increased even further to the point where if you have macular pigmentary changes in soft drusen in both eyes and you have reticular pseudodrusen or subretinal drusenoid deposits, you have a 70% risk of late AMD in at least one eye over 5 years. And here I'm just illustrating for you how this grading system can work in clinical practice. On the left, this person has bilateral soft drusen, so they have a 12% risk of late AMD in 5 years. This person has bilateral soft drusen and reticular pseudodrusen, so they have a 30% risk. This person has bilateral soft drusen and reticular pigmentary change, subtle but pointed out by the black arrow. And so they have a 50% risk of late AMD in one eye in 5 years. And this person, unfortunately, has everything: bilateral soft drusen, bilateral reticular pigmentary change, and bilateral subretinal drusenoid deposits. So they have about a 70% risk. Well, when I say risk of late AMD, you might be wondering, well, how does that break down? I mean, what's the chance of geographic atrophy? What's the chance of choroidal neovascularis? Well, it turns out it's about a 50-50 chance. So what do choroidal neovasculars look like clinically? Well, that's actually shown here that in the infrared photograph on the left, you may not be able to recognize the vessels, and typically we can't. And historically, what we did to visualize the abnormal choroidal vessels was a test called fluorescein angiography, where you inject a fluorescein dye into the antecubital vein. Then you illuminate the eye with light in the wavelength between 465 and 490 nanometers, and then it fluoresces, the dye fluoresces in the range between 520 and 530 nanometers. And what we're visualizing in this angiogram is the fluorescent light. And so any vascular structure will fluoresce. And in this case, the abnormal vascular structure is the choroidal new vessel. But it's actually much easier and faster to visualize the choroidal vessels using optical coherence tomography. And you can visualize that abnormal structure underneath the retinal pigment epithelium in this very same eye very quickly and identify the choroidal neovascularization. You can use OCT to identify atrophy too. So the normal fovea is shown on the left, normal thickness of the outer nuclear layer. And on the right, you can see the outer nuclear layer in the fovea is quite thin. And in addition, you see a hypertransmission signal in the sclera. And the reason that's there is because the retinal pigment epithelium is attenuated. So there's nothing interfering with the transmission of light through Bruch's membrane into the sclera. And you might just contrast that with the appearance of the sclera and the normal fovea. So there's nothing to say you can't have everything. It's sort of like the book of Job, there's nothing to say that everything can't go wrong. And here's an unfortunate person. You have soft drusen, you have macular pigmentary change, you have geographic atrophy, and you have intraretinal and subretinal hemorrhage associated with an occult choroidal new vessel. Well, the histopathology, I think, is worth looking at to understand, at least to have a good theory of the pathophysiology of the disease. So before I show you the histopathology, I want to show you the structure of the choroidal circulation, which is essentially a sinusoid. So what you have is a feeding arteriole supplying a lobule of the choriocapillaries, and then these naturally would drain into venules. And we can actually look at this with en face imaging of postmortem eyes. So in the upper left, you have a fundus photograph of an elderly patient that doesn't have AMD. And then along the top row, the postmortem photographs of the fundus. And we can create en face images of the choriocapillaris by staining the choriocapillaries with a dye called Ulex europaea agglutinin. And what you can see in the lower right is what is really a normal choriocapillaris lobule. And just to drive that point home, I'm showing the SEM image of a normal lobule for comparison. Now, if we instead look at the eye of a woman with early AMD, just early AMD, and there's the postmortem area that we're going to focus on, and then look at the en face image of the choriocapillaris, what we see is that in that area, it's dark. And the reason it's dark is because there's a decreased capillary density under the fovea. And if we look under even higher magnification, what we'll see is that there are areas where we simply have no capillaries at all, pointed out by those asterisks. And that's in contrast to an area outside the macula where the choriocapillaries are entirely normal. What's even more interesting is if we look at the edge of this perfused, non-perfused border, we will identify neovascular buds. And this has led to the idea that choroidal neovascularization is actually a homeostatic response to choroidal ischemia. And, based on what I've told you about the oxygen utilization of the photoreceptors, you can imagine how sensitive they are to hypoxia. And what happens in setting of hypoxia is the RP cells will upregulate hypoxia-inducible 1-alpha and then increase vascular endothelial growth factor production. And that's probably the way you get the choroidal new vessels. So here we can also visualize what the choroidal new vessels look like histologically. I've shown you this patient already. The Ulex europaea agglutinin stain of their choroidal vessel is shown in this uh, panel D. And if you look, you can recognize that the area just outside the choroidal vessel is dark, which it goes along with the idea that the choroidal vessel is a response to choroidal ischemia. And if we look at the border of the choroidal vessel, we see, yes, in fact, there is choriocapillary dropout, in contrast to the extramacular choriocapillaris, which looks fine. And then if we look at geographic atrophy, and you'll not at all be surprised to see what I'm about to show you, that area of atrophy looks dark, and it's dark. If you look under high magnification, what you see is that there's a loss of choriocapillaries. The ones that are present have attenuated luminal diameters. That's at the border of this atrophy, you actually see frank areas where there are no vessels. In fact, normally, the choriocapillaries occupy about 83% or 82% of the surface area. And in these areas of atrophy, in this particular case, 38% is occupied by vessels. But more than that, the luminal diameter in these abnormal areas is about 9 microns. Normally, it's close to 20 microns. So when you look at this patient, so this is a person that has choroidal neovascularization, and they've had it for a while, 11 years, and their vision's 20/30, and they've received this anti-VEGF therapy that I'll describe in more detail in a moment. And what's really striking is they have this area of geographic atrophy, but it has not invaded this area. And you might say, what is sparing that area from atrophy? And the answer is on the OCT. The en face OCT image is showing you that right in that area, there's a choroidal new vessel, which you can see easily with a transverse OCT image. And you might say, well, why hasn't this vessel caused the person to go blind? And the answer is that the anti-VEGF therapy has allowed this abnormal vessel to retain much more normal permeability properties so that it's not associated with leakage of fluid or bleeding. All it's really doing is supplying oxygen to the fovea, which is what it's really supposed to do. So when we look at choroidal new vessels, the way I think we should think about it is that they are pathological vascular growth in response to inadequate choroidal blood flow, whereas areas of atrophy are areas of inadequate vascular growth in response to inadequate choroidal blood flow. Well, what causes these changes in the choroid? Well, the current theory is that chronic low-grade inflammation damages the choroidal capillaries and the RPE cells. And if the damage is severe enough, you can get atrophy and/or choroidal neovascularization, which, of course, leads to the view that I've proposed, which is that choroidal neovascularization is just a homeostatic response to choriocapillary damage. Now, what's the evidence for this inflammatory concept? Well, there's a variety of pieces of evidence, but let's just start with the composition of drusen. They contain components of the activated complement cascade. So complement receptor 1, various complement factors, amyloid beta peptide. We also can identify inflammatory cells in RP Bruch's membrane. Here's an HLA-DR positive cell in a drus and a CD86 positive cell in a drus and in Bruch's membrane. We can also identify bioactive fragments of complement. Here's C3A in A and C, and C5A in E and F in a patient, 87-year-old donor with drusen. And what's interesting is that it's been known for a long time that if you have confluent soft drusen, you have an increased risk of choroidal new vessels. This may be one of the reasons why. So the idea is that these pro-inflammatory molecules in drusen create a stimulus for chronic inflammation in the RP Bruch's membrane choriocapillaris complex, which leads to some features of AMD. Now, I'm sure you're all familiar with this slide, which shows the classical, the lectin, and the alternative complement pathways. But the point is that the C3 is the key point of convergence of all the activation pathways. And of course, C3 splitting leads to C3A, which is anaphylatoxin, and C3B. C3B then activates C5, which gives you C5A, also an anaphylatoxin, and C5B. And C5B combines with C6, 7, 8, and 9 to create the membrane attack complex. And of course, if you get enough of these pores forming on the surface of the cell, you'll get hydrolytic death of the cell. And you all know from medicine that inappropriate complement activation can damage tissue. I think that a great example is type 3 glomerulonephritis, which interestingly enough is associated with drusen formation. As it turns out, it's been documented that mutations in multiple components of the complement pathway have been linked with an increased risk of AMD. I'm circling in green components whose mutation has been documented to be associated with an increased risk. For me, I think I keep in mind this idea that the alternative complement pathway is continuously activated in the fluid phase. And so any tissue surface that's exposed to the fluid phase has to continuously regulate complement activation. Otherwise, it's at risk for spontaneous autologous cell injury. So here's just some immunopathology showing C5 deposition in a small drus, in a large soft drus, MAC deposition in the RPE and in drusen material. And here you have MAC deposition in the choriocapillaris. capillaris. This is all AMDIs. Now, you can do this more systematically, and this has been done, looking at the immunopathology in patients with AMD, comparing the immunopathology in patients with early versus intermediate versus advanced AMD. And as you might expect, what you find is that as the disease severity increases, you get increasing deposition of complement factor B, complement factor D, complement C3, and complement C3A, but not C4A. All told, so far, there are about, well, more than 40 loci implicated with increased genetic risk for AMD. But in the aggregate, genetics probably only accounts for about 50% of the risk. I'll show you some of the other risk factors in a minute. This is a genome-wide association study showing some of the very important genetic risk factors. So complement factor H, very important, CFI, C9, C2CFB, and C3. There's another very important genetic risk factor, which is a mutation in a gene called ARMS2 or HTRA1. ARMS2 is age-related macular susceptibility gene 2. And the point I want to make here is that the complement factor H, which is a very important risk factor, a Y402H mutation, is an independent risk factor from the ARMS2 mutation. So they operate independently. And the additional point I want to make is that these risks, genetic risks, seem to operate very early on in the disease pathogenesis. In other words, it's not that CFH is increasing your risk for atrophy and RMS2 for neovascularization. No, it doesn't work that way. They just both increase your risk for having AMD, which tells me that complement activation plays a role very early on in the disease pathogenesis. Now, I'm showing this table for a funny reason. This is a study actually demonstrating that the risk alleles for CFH and ARMS2 are independently associated with systemic complement activation in patients with AMD. But I actually don't want to show you the genetic information first. I want to show you the non-genetic information. So if you look at the risk of having AMD, if you're a current smoker, you have a threefold odds ratio of close to 3 compared to the controls. But what's really interesting is if you're a past smoker, your odds ratio is 0.87. And what I think that means is that this is a reversible environmental risk factor. So if you smoke, you should stop smoking because it will reduce your risk. Another potentially reversible risk factor is the body mass index. If you have a BMI greater than 30 kgs per meter squared, again, your odds ratio is 3. And if it's less than that, it goes down. So maybe that means that lowering your BMI will lower your risk. But let's look inside the genetic risk just for a minute, because I think there's something interesting to learn here. If you have if you're homozygous for the CC allele, that's the highest risk you can have from a complement factor H mutation perspective. And that increases your risk for AMD by about 9-fold. But you can be homozygous for that risk allele and still not have AMD. About 15% of the controls fall into that category. Similarly, if you look at the RMS2, the A69S mutation, so homozygous for TT, yeah, it increases your risk for having AMD by almost 16. But about 3% of the patients who were controls were homozygous for that very high-risk allele. So that means, first of all, the genes aren't everything, but it might mean also that there's some protective mutations that occur. And sure enough, if you look at complement factor B, if you're heterozygous with AT, your risk of AMD is reduced, odds ratio of 0.38. So the genes, as you might imagine, can increase or decrease your risk. But it's not going to totally determine whether or not you get or don't get the disease. Well, how might this whole thing work? So one scenario, I'm just illustrating. So if you have C5a, it binds to its surface receptor. That leads to activation of NF-kappa B, which leads to increased transcription of NLRP3, procaspase-1, ASC, and pro-interleukin-1 beta and pro-interleukin-18. And then if you get a second signal, which could be C3a binding its receptor working through the P2X7 receptor, or it could be increased reactive oxygen species due to oxidative damage of the mitochondria, or it could be lysosomal damage with the release of cathepsin B into the cytoplasm. But that second signal will initiate the NLRP3 inflammasome assembly, which activates caspase-1, which leads to the production of interleukin-1 beta and interleukin-18, which leads to cell death by pyroptosis. Now, you know, with apoptosis, the cell dies with an intact cell membrane, and that material is eliminated by phagocytosis. But with pyroptosis, the membrane's lysed, and that leads to the release in the local environment of inflammatory cytokines, which kind of creates this situation where you can get this contiguous spread of cell death. And that, of course, is exactly how geographic atrophy looks like it spreads. Although this all underlies consideration of treatment. And for wet AMD, we have basically two strategies at the moment. One is antivascular endothelial growth factor therapy, given intravitreally through a sustained delivery system. And then emerging now combination therapy, which I'll spend a little bit of time on. And then for dry AMD, we have the recently approved complement inhibitors, the experimental cell transplants, and a recently improved technology called photobiomodulation, which I'm just going to mention for completeness because I'm not confident of how well it actually works. Regarding the neovascularization, remember the choriocapillary damage is very rapidly going to lead to hypoxic signal, which has been demonstrated to increase hypoxia-inducible factor 1 alpha production with VEGF production. And while VEGF does stimulate the growth of these capillaries, they leak and bleed and basically don't just supply oxygen, they supply toxins too. So we try to block VEGF signaling. That's what the anti-VEGF drugs do. We've injected them intravitreally for about 20 years, and they really do work very well, but they do have limitations that I'll mention. The ones that we tend to use in the United States are bevacizumab, which is a full-length antibody interfering with VEGF-A signaling, ranibizumab, which is an Fab fragment that interferes with VEGF-A signaling, aflibercept, which is a fusion protein that interferes with VEGF-A, VEGF-B, and placental growth factor signaling. In Asia, they tend to use conbercept, particularly in China, which is a fusion protein that interferes with VEGF-A, VEGF-B, VEGF-D, and placental growth factor signaling. Brolucizumab is a single-chain antibody fragment that interferes with VEGF-A signaling. It's approved for use in the US and Europe, but it's a third-line drug because it has a 3% incidence of very severe occlusive vasculitis. So here's how we administer the medicine. We have a patient reclining with a steroid speculum in place with topical anesthesia. We sterilize the ocular surface with povidone iodine. And then with a drug in a TB syringe attached to either a short 30 or 27 gauge needle, we inject through the pars plana into the vitreous cavity. And here's an example of an unusually responsive patient. He presents with a choroidal new vessel, 20/40 vision. Hard to see clinically, but with a fluorescein angiogram, you can see that early hyperfluorescence with very profound dye leakage in the later frames of the angiogram. It's much easier rather, to see the subretinal fluid in this very early generation OCT. He gets a series of ranibizumab injections, does very well with recovery vision to 20/20. And eventually, about a year later, returns with a little bit of fluid and a little bit of decreased vision, gets a repeat series of injections, does really well, and he stays without any need for injections for about 5 years. This is a very unusual patient, number one, because he retained excellent vision throughout the course of his treatment, and number two, because he required so few injections to do so. What are the limitations of anti-VEGF therapy? In a nutshell, efficacy, and durability, and the risk of atrophy and fibrosis. And I'll go through those systematically. First, efficacy. What I'm showing you here is what amounts to what I think is a ceiling effect for all the anti-VEGF drugs. So if we look at the Harbor trial, a prospective multi-center randomized clinical trial, comparing two different doses, 0.5 and 2 milligrams of ranibizumab, you see they look the same. You get about 8 letters of improvement. We're plotting here on all these graphs. Change in vision on the y-axis is a function of time on the x-axis, 8 letters of improvement over the course of a year. In the VIEW trials, which were registration trials comparing aflibercept to ranibizumab, you can see same visual outcome, about 8 letters of improvement over the course of a year. The CAT trial, multi-center prospective randomized clinical trial comparing ranibizumab with bevacizumab, about 7 letters of improvement over the course of a year. And then Tenaya and Lucerne, which are registration trials comparing aflibercept and this bispecific antibody, which I'll tell you more about in a minute, about 6 letters of improvement. The point is, we need to try to find a way to get more visual improvement. Now, the second limitation I mentioned was durability. I'm illustrating here with the results of the CAT trial. What we're plotting is visual acuity on the y-axis is a function of time on the x-axis. And you can see at the start of the trial, the patient's average vision was about 20/60. Then it improves during the trial to around 20/40. And then the trial ends, and so, the patients are followed sort of in a phase 4 manner. And the vision declines afterwards. Why is that? Well, it turns out that during the course of the trial, they were treated with monthly injections. But after the trial ended, they got about 5 injections a year, which is about half the number they should have gotten. And this just makes the point that for most people, they require many injections over many years to preserve their vision. And, that's logistically not an easy objective to achieve. Europe is even worse. The best country is the UK, where you see about a 6-letter improvement after 3 months, followed by Netherlands, then France, then Germany, Italy, unfortunately, really bad. And by 2 years, the results are really pretty bad. Again, UK is the best with 4 letters, followed by Netherlands, then Germany and France, and then Italy, where they actually lost vision. So in the European experience, in the real world, they get about 2 letters at year 1 and a half a letter at year 2, compared to 8 to 11 letters, which was seen in the registration trials. Why? Do they get worse drug? Do they have worse doctors? No. They have fewer injections. They get a mean of 5 injections in the first year and 2 in the second year. So, how do we approach this durability problem? Well, one way is to provide sustained delivery systems, and that's what we're showing here. This is the Susvimo delivery system, which is FDA approved and in practice. The cartoon of the delivery system shown here, you can actually see it in a human patient. And this is what it looks like externally looking through the conjunctiva. About 98% of the patients require only 1 injection during 6 months. About 60% of them require only 1 injection after a year. And we inject through the conjunctiva into the reservoir to refill it. The problem with this system is that it has a much higher rate of endophthalmitis compared to intravitreal injection, and it has some complications which simply aren't observed with intravitreal injection, like implant dislocation or conjunctival erosion over the implant. So it hasn't really gained, in my opinion, very broad acceptance. Another way to try to attack the durability problem is with combination therapy, which I've alluded to. So, very briefly, angiopoietin-1 binds to the Tie2 receptor, tyrosine kinase with immunoglobulin domains and endothelial growth factor. And this binding leads to increased production of occludin and claudin, so better tight junctions, better pericyte coverage, better vascular integrity. Unfortunately, if you have a stress like hypoxia, you start to increase your Ang2 production. Ang2 is a mixed agonist-antagonist that competitively interferes with Ang1 binding to the Tie2 receptor. And as a result of that, you get decreased occludin and claudin production, you get increased inflammatory cytokine formation, you lose pericyte coverage, you get leakiness of the vessels. And of course, under these circumstances, you also have increased VEGF-A production, which is going to promote uncontrolled and abnormal vessel sprouting with immature vessels that leak fluid and blood. So the idea is if you could simultaneously inhibit Ang2 and VEGF-A, then you could actually stabilize the endothelium and reduce fluid leakage and get just that oxygen delivery from the new vessel and nothing more than that. And that's actually what faricimab is intended to do. It's a bispecific antibody where one arm, FAB, interferes with Ang2 signaling and the other arm interferes with VEGF-A signaling. And then there's a specially designed FC component to reduce systemic exposure to the drug, as well as reducing the inflammatory potential of the molecule. And in fact, in the registration trials, it turns out that faricimab patients were able to go every 12 to 16 weeks on average, 80% of them, every 12 to 16 weeks with just 1 injection. In fact, half of the patients could go every 16 weeks with just 1 injection. So that, I think, does help the durability to some degree. Of course, a better solution for durability would be gene therapy, and that's in very late stages of testing now. I'm illustrating with one company. They're using an AAV8 vector and delivering a molecule that really resembles ranibizumab. This can be administered with a vitrectomy and subretinal injection in the operating room, or more easily, it can be administered with a suprachoroidal injection in the office. And the AAV8 was used because you get better delivery to the RPE than the AAV2, which is the other FDA-approved vector. And the RPE is where we need to really produce the VEGF inhibition. So obviously, quite a great potential for long-term VEGF suppression with this approach. Here's just some results from one of the early phase trials where we're plotting the letters read on the y-axis as a function of time on the x-axis. The control group retains very good vision, 20/30 vision during the course of this small study, but at the expense of having to get 7 ranibizumab injections. The treatment groups, which have different doses of vector, also achieve excellent stabilization of vision, but with many fewer injections. And if that's all there was to it, I'd say gene therapy is going to take over the therapeutics of this disease, but it's not all there is to it. And that brings us to another problem, which is the one of atrophy. Now, this was first detected in the CAT study, which I've mentioned, and in the IVAN study, which also compared ranibizumab to bevacizumab, which was conducted in Europe. And what they found is that among patients that entered the trial with no atrophy, about 20 to 25%, let's say, developed atrophy over the course of 2 years of injections. And this was reproduced, unfortunately, in the Harbor trial. So the evolution of atrophy is something that really does occur in part as a result of the anti-VEGF therapy. And it occurs in a very high percentage of people by year 8, and unfortunately can be associated and may contribute to a poor visual outcome. So there's lots of improvement, room for improvement with these drugs. And the last area of improvement is the development of fibrosis, which is shown here, which is a very late manifestation of choroidal neovascularization, but it does make visual loss even worse, and it would be good to have a way to inhibit it. Well, what about the treatment of atrophy? Well, atrophy spreads in a very funny way. Typically, it starts extrafoveally, and then it kind of wraps around the fovea over time in most patients, eventually hitting the fovea. And of course, as that process occurs, and it occurs generally over a period of 2 to 5 years, you get corresponding reductions in visual acuity with really loss of the ability to live independently. And, based on what I've told you already, you can imagine why complement inhibition might be a strategy to treat this problem. Blocking C3a and C5a could be helpful for inflammasome activation and membrane attack complex formation modulation. And that's why C3 and C5 inhibition were identified as targets for treating GA and even earlier stages of AMD. So it turns out that one molecule, pegcetacoplan, blocks C3 breakdown, and it is a 13 amino acid cyclic peptide that's pegylated. The way it works is by steric hindrance. It prevents the binding of circulating C3 to surface-bound C3bBb, which reduces the production of C3a. And here are the 2 registration trials, OAKS and DERBY, where every other month and monthly injections were compared. And you can see that there's a modest but very significant reduction in the rate of geographic atrophy. In OAKS, anywhere between 8 and 22%, depending on if you got every other month or monthly injections, and in DERBY, 16 and 19%. There is an important complication associated with complement inhibition, and it's the development of choroidal neovascularization, which tends to occur in about 10% of the treated group versus, say, 2 to 3% of the sham group. There's also intraocular inflammation. Now, in the study, this inflammation could be controlled with topical steroids, but in phase 4 studies, it turns out that there's about a 1 in 10,000 chance of a severe occlusive vasculitis, which can cause total blindness. This severe inflammation really tends to only occur after the first injection. So if you look at the incidence after first injections only, it's about a 1 in 4,000 risk. The other molecule that's been approved, which blocks C5 enzymolysis, avacincaptad, it's an RNA aptamer, that's pegylated. It's administered intravitreally. And here you can see the results from one of the registration trials called GATHER2, where every other month and every month were compared, and very similar to pegcetacoplan, 14 and 19% reductions. What's also interesting about this drug is, as you might expect, it also prevents the development of earlier stages of AMD from progressing to later stages. So on the left, you see a person that has a large soft drusen, which evolves into a small area of atrophy. That's the sham. The treated patient in this selected example doesn't so develop. But if you look at the data in the aggregate, 27% of the patients who had just drusen did develop areas of atrophy, as opposed to 7.6% of those who were treated with the Avastin Captad. So it reduced the progression of drusen to early and late stages of atrophy, as you would expect it would. This drug also has an increased risk of choroidal neovascularization, unfortunately. When would we treat a patient with geographic atrophy? Well, probably not when they're 20/20 and have just some small areas of atrophy. As the area of atrophy progresses and the fovea becomes threatened and they're still 20/20, we could certainly have a debate about whether we should treat such a patient. Almost certainly, when the vision begins to decline, I think it would make sense to at least offer that possibility to the patient, recalling that there's going to be an exponential decrease in the visual acuity associated with a linear increase in the spread of atrophy. Here's an example of a treated patient. This person was enrolled in the OAKS study, enters with 20/60 vision in one eye, 20/30 in the other. The eye with 20/60 was randomized to treatment. By 30 months, they actually had visual improvement to 20/30. They start out with about 4.3 millimeters squared of atrophy, and that increases by 1.7 millimeters squared during the course of the study. Now, unfortunately, the fellow eye, their vision declined to 20/80. They started out with 4.8 millimeters squared of atrophy, and the increase was much greater, 4.9 millimeters squared, which underlies the fact that their vision decreased. Now, very briefly, some experimental therapies, RP transplantation. It turns out that the initial RP transplants, in my opinion, were not very successful, probably because the RP can't survive on the abnormal Bruch's membrane. So Mark Humayun at USC developed this Parylene C membrane. It's a nano-engineered membrane that's 6 microns thick, but it has these engineered 0.3 micron diffusion zones in it. They are about 40 microns in diameter and occupy about 58% of the surface area of the scaffold. Here you can see one of the scaffolds covered with iPS-derived RPE. Under high magnification, you can see there's a very nice cuboidal pigmented cells. Here's one of Mark's patients who starts out with reading 7 letters, has a large area of atrophy, undergoes a transplant. You can see the scaffold under the fovea. 120 days later, they can read 24 letters. There's still a lot of issues with this technology, but it's an emerging strategy. Photobiomodulation therapy was just recently approved by the FDA. That's why I'm mentioning it. The idea is we stimulate the respiratory chain, and in model systems that does promote cellular proliferation and cytoprotection. It turns out that cytochrome C oxidase is a photoacceptor, especially of far red and near infrared light. And when so stimulated, it promotes ATP production. So there was a study conducted where patients were irradiated with 590, 660, and 850 nanometer light, these short pulses. The sham treatment couldn't get no light because they could see they weren't getting any light. So they were delivered what was thought to be homeopathic levels of fluence. And this is the machine. You put your chin right in there. And so the way it works is you're randomized to sham or photobiomodulation therapy. And then at baseline, the PBM treatment patients get these 9 treatment sessions delivered over 3 to 5 weeks. And then this is repeated at month 4, 8, 12, 16, 20, with a readout at month 13. And what you see is that the photobiomodulation patients have a better visual outcome. So we're plotting the percentage of eyes on the y-axis as a function of letter improvement on the x-axis. So more of them got 5 letters, more of them got 10 or more letters, more of them got 15 or more letters of visual improvement compared to the sham, which is, of course, why this thing was approved. Here you can see a patient who starts out with 75 letters and large subfoveal drusen. 13 months later, there's 79 letters of reading, and the drusen are gone. And in fact, if you measure the drusen volume, in the treatment group, it was about 0.05 millimeters cubed as opposed to 0.05 millimeters cubed in the sham group. So that's a 10%, a 90% reduction in drusen volume increase. If you look at the risk of geographic atrophy, about 10% of the patients develop some versus 1% of the photobiomodulation group. So maybe this is a good treatment. It's too early for me to say, for me to advocate it. How do we approach the patient with AMD? Well, we start with a history, as you might suspect, because if they have something that looks like AMD and they're age 35, the odds are that that's not what they have. They could have an inherited retinal disease that's mimicking AMD, or they could have a systemic disease like type 3 glomerulonephritis, or they could have toxicity. So, for example, hydroxychloroquine or pentosan polysulfate sodium are toxic to the retinal pigment epithelium. Also, they may be smoking. We want them to stop smoking. We want them to lower the BMI. The family history, we're looking for autosomal dominant inheritance, number one, to rule out masquerade syndromes, but also if they really do have autosomal dominant AMD, we're probably going to start a vitamin and mineral replacement therapy in them at an earlier age than we otherwise would. The physical exam is important because, as I told you, it's a great way to stage the disease without knowing anything about their genetic background or smoking history. The tests we're most likely to use are going to be the OCTB and A tests. Occasionally, we'll use fluorescein angiography if we're not sure of the diagnosis. Genetic testing, I would only do to rule out mimicking diseases at this point in time. And similarly, fundus autofluorescence is only to rule out masquerade syndromes. The only vitamin supplements that I know of that have been improved in a prospective multi-center randomized clinical trial are the AREDS 2 vitamins, which contain lutein, zeaxanthine, cupric oxide, and zinc oxide. They've been documented to reduce the risk of moderate visual loss by 19% during a 5-year period of follow-up in people with intermediate or worse AMD. I might consider recommending them for people with early AMD if, for example, they have autosomal dominant disease. Smoking cessation, of course, is critical at possibly stopping some medications that I've alluded to, pharmacotherapy that I've spent some time discussing, and potentially photobiomodulation therapy. So in summary, it's the leading cause of blindness among people over the age 55 in the industrialized world. The risk factors are age, genes, especially CFH and ARMS2, and environment, especially smoking and BMI. Pathophysiology, most likely it's chronic inflammation with secondary choriocapillaris, RPE, and photoreceptor damage. Established therapy exists, maybe not as effective as we'd like, but it exists for intermediate AMD, neovascular AMD, and atrophic AMD. And the therapies that are in development that have promise are cell-based, gene, and photobiomodulation therapy. I can say the pluses and minuses of each of them. I think the only way we'll really know how much they're going to fit into our armamentarium is with continued, very systematic clinical trial testing. Thank you very much for your attention. In the few minutes that remain, I'd be very happy to answer any questions that you might have.
Dr. Zarbin, thank you so much for this tremendous overview of this very important, obviously, clinical problem and understanding really the pathophysiology and approaches to therapy and what we have seen and what is yet to be done. Really appreciate that. So encourage folks to either put their question in the chat, or raise their hand, or just speak up. That'd be great. While we're waiting for that, it's just really fascinating. And I mean, this balance that has to be waged between this neovascularization, the atrophy, and actually the treatments that also kind of seem to impact both sides of that equation. But let me just ask something first, maybe in a very simple kind of way. As internal medicine doctors, is there something about a patient's presentation, complaint about vision, or things we should be asking if we lost you there, there you are.
I'm there, but I want to share the slide. Yeah, go ahead.
Sure, thank you so much for doing that. Or things that we should be asking patients, because making the diagnosis earlier seems to be much better. Is there any specific visual complaint that should raise our concern about patients maybe developing AMD, and we should get them over to the ophthalmologist?
Not the word specific I want to focus on. The answer is, if you use the word specific, the answer is no. But something you can easily do is ask if they have a family history of AMD. Because if they do, then they probably should be seen. But, the American Academy of Ophthalmology recommends that anyone over the age of 45 have an eye exam every 2 years. and anyone over the age of 65 have an exam every year. So that's a simple thing to do. I doubt that many of you are looking in the fundus with direct ophthalmoscopes, not the least reason being that you're not dilating your patient's eyes. If for whatever reason you were doing that, it would be very easy to identify patients that have intermediate AMD because you will absolutely be able to see the drusen. So Mark, I would say if they have decreased vision, if they meet the age criteria, if they have a family history, those are people who I think should just probably routinely be referred to an ophthalmologist.
Very good. Thanks so much. Again, anybody have any questions, please, of course, feel free to raise your hand or speak up or put it in the chat. While we're waiting, Dr. Deaver, go ahead, sure.
Yes, thank you so much, Dr. Zarbin. One of the reasons I asked is I feel like in the last 10 years, I have more and more patients with the diagnosis. So is it part that there's more treatment now? So then it becomes that, we're seeing patients that are actually being treated. Is it being increasingly diagnosed? Is the prevalence increasing? And then the second question I have is access to these expensive therapies.
Yeah, well, the prevalence is absolutely increasing as our population ages. It's also increasing as our population BMI increases. I forget the number of pediatric patients that are obese. I think, but we're seeing childhood diabetic retinopathy now that I never saw 30 years ago. So I think it's a prevalence issue. In terms of the access to the drugs, a very important detail, the drugs cost about $2,000 an injection. And it turns out that and we take care of patients, as you do too, with all sorts of uncoverage or lack of coverage. All the various coverages, Medicaid and the HMOs, Medicare and the HMOs, commercial, they all cover the cost of the drugs. For the patients that have literally no coverage, so those would be the charity care patients, the drug companies actually have programs that will specifically provide the drug. So there really is no coverage reason why the patient can't get the injection. The only issue we have inside university hospitals, we need the patient to apply for charity care and get it. And then literally, once that step has been achieved, there's literally no one that can't get the drugs. But I will say that the insurance companies do regulate which drug you can give, though. So some of them will let you give aflibercept, but not faricimab. There's no logical reason for that, in my opinion, because the drugs' costs are very similar to each other.
And also I was thinking about, that Henry Winkler does that commercial for GA, right? So, I mean, it's out in the media, as well. And he doesn't even say what GA is. So I'm assuming it's, aimed at people who have the diagnosis.
Well, I didn't have the time to emphasize it, but in my opinion, there's very little clinical judgment involved in deciding whether or not to inject a person who has choroidal neovascularization. But there's a lot of clinical judgment involved in deciding whether or not to treat a person with GA. First, because the benefits of the drugs are very modest. Second, because they have a small risk of a very serious complication. And third, because of the way time is different. Time in choroidal neovascularization moves very rapidly to visual loss. In GA, it moves very slowly. So you have to really listen to the patient and hear what their visual needs are, understand what their risk tolerance is, understand what the logistics will be for them to come in and get the injections basically for the rest of their lives.
Thank you.
Thanks, Dr. I'm going to go to Dr. Weinberger in a second. Just quickly to follow up around, obesity is this nexus between diabetes, hypercholesterolemia, hypertension, and of course we see a lot more obesity. There are drugs for treating obesity, probably maybe a little bit too early, but we're seeing in some of these trials with the anti-obesity medications, improvements in cardiovascular outcomes. We see dropping of cholesterol levels. We see improvement in diabetes. Are any of those targets, and is that interface important, you think, here as well?
Yeah, I think it probably is going to be. And one thing that I think is really underemphasized is the importance of your diet. And I think the proof of that is looking at the children with obesity. So, in addition to all these medicines, I don't know how to operationalize this, but people have to actually start changing what they eat.
Dr. Weinberger?
Thank you. I'm not sure I followed entirely your complement cascade and which parts are much of a problem here, but what about a drug like avacopan, a C5 inhibitor, and it's oral, no needles in the eyeball?
What now? Tell me how where does it work in the complement sequence?
It's a C5
Oh, C5 inhibitor. Oh,
inhibitor.
absolutely. It could work. And believe it or not, eculizumab was tried initially for this problem, and it failed. And yet here I'm just showing you data with avacincaptad, which is a C5 inhibitor, and it worked. And I think the reason is how much drug actually gets to the choroid and how long it stays there. Because obviously eculizumab does work for paroxysmal nocturnal hemoglobinuria, but it really didn't work when administered systemically. But that's one of the things I'm hoping for, is that someone in the audience is going to think of a drug that might really be good, and maybe all we need to do is change the route of administration in order to have a new drug. And the more drugs we have, I think everyone recognizes this, the cheaper they all get.
Dr. Zarban, unfortunately, our time is up for today. I really want to thank you for just a wonderful, wonderful talk, and really opening up a door to just this fascinating and biologically interesting and treatable problem. And I think it's really informative for all of us. So again, thank you very, very much. I want to thank everybody for joining today, and just wish everybody a great rest of the day. Thank you.
Bye, everybody. Thank you for inviting me.